Good evening to everyone. This is Batul, the moderator for today's session from IGCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, he needs no introduction, but yet it's our great pleasure and honor to introduce him. He is none other than the very renowned nephrologist, Dr. Ratan Jha, sir. Sir is senior nephrologist and transplant physician at Care Hospital, Banjara Hills, Hyderabad. With Sir's wonderful insight, we are going to talk about the topic for today, which is treatment of osteoporosis in CKD. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his patience, Dr. Boone. So, over to you.
Good evening, friends. Today's talk is on osteoporosis in CKD. What are the choices of drugs and other therapies which are non-drug therapy in this context? Because it's a very complex topic, and hence I thought that it's good to talk about this, which is a common kind of problem in patients of chronic kidney disease. So my talk is going to address the following issues in context of chronic osteoporosis and kidney disease. We'll talk about the concepts of this osteoporosis in the background of kidney disease, how this thing has to be understood. What are the clinical suspicions for osteoporosis in CKD? That is, how do you suspect it, and what are the diagnostic tools to make the confirmed diagnosis of osteoporosis? What are the treatment options, the non-pharmacological therapies as well as the pharmacological therapies, and how to choose these options in different patients? The 10-point clinical approach in when we see a patient of osteoporosis will be a clinical way to look at the thing, and what are the algorithms which we can utilize to make the treatment simple. And finally, we conclude what is the message from my presentation. So, introducing the concept that is osteoporosis, CKD, how it is important. It has been reported that patients of chronic kidney disease have almost 4 to 5-fold higher rate of fracture compared to general population. The patients of chronic kidney disease suffer from the bad bone health, which is deterioration of bone quality as well as quantity. The DEXA scan that we commonly do provide information only about the quantity of bone, but not the quality which is at stake in patients with chronic kidney disease. In this context, the trabecular bone scoring, high resolution bone imaging, invasive bone biopsy, bone turnover markers are available to some extent, which can guide the mechanism of bone loss and drug treatment appropriately. So, when we talk about the bone health in chronic kidney disease and the problem of osteoporosis, one has to remember that there is a multifactorial background of traditional as well as non-traditional risk factors which increases the bone fragility, which is the common consequence of the bone health deterioration. The traditional risk factors for chronic osteoporosis in a patient of chronic kidney disease are age-related bone loss, hypogonadism, because we know that sexual dysfunction happens in patients of kidney disease, poor nutritional status because of malnutrition, and reduced physical function. So all these things are common to the CKD population as well as a non-CKD population where it produces the risk of osteoporosis. The systemic illnesses which are associated with chronic kidney disease are add-on kind of point, like diabetes, endocrine disorders like hypo or hyperthyroidism or hyperparathyroidism, hematological diseases like multiple myeloma and other kinds of bone blood disorders, malabsorptive states which may be associated with chronic kidney disease, which can influence the bone health. Polypharmacy, that is a very important kind of point that has to be remembered, that patients of chronic kidney disease are getting multiple drugs because of the associated comorbidities, including immunosuppression, which can have effect on bone health like steroids, drug affecting mineral metabolism like diuretics, drug affecting the risk of fall, like particularly the gabapentin group of drugs given for pruritus and pain. The CKD associated factors, which may be also important in contributing to the osteoporosis, are early onset of chronic kidney disease, like in childhood, when the bone peak mass usually happens, which is getting interfered. Time on dialysis, that is vintage on dialysis, the longer the duration, longer the chances of osteoporosis, chronic inflammation of chronic kidney disease, metabolic acidosis, and a mineral metabolism disturbance of vitamin D deficiency as well as resistance, which can lead to a bone ill health or osteoporosis and other kinds of consequences of CKD. So the treatment plan will factor not only the ultimate out kind of bone quality and quantity, but also it will have to look at the risk factor which can be treated. And bone health is always measured in terms of TMV, that is what is the bone turnover, what is the bone mineralization, and the bone volume. And osteoporosis is a situation of reduced bone volume with reduced kind of bone quality that has to be treated adequately. When we talk about bone, we need to understand that there are two types of bone in our skeletal system. Cortical bone, which constitutes about 80% of bone mass, while trabecular bone, which constitutes 20% of bone mass. The trabecular bone is cancellous, spongy, and more fragile and voluminous, as shown in this cartoon. That is the rib cage, the pelvic bones, the skull bones are more trabecular than cancellous, while the limb bones, particularly humerus, uh, radius, ulna, uh, femur, tibia, and fibula, are considered to be predominantly cortical bone. So the trabecular bone is a bone which is more metabolically active, and it is associated with uh, various other kind of metabolic functions, including production of the blood, that is RBC. And hence, one has to understand that bone function is not only mechanical, but it also has a metabolic function. So the topic that we are going to basically cover today is osteoporosis in the context of chronic kidney disease. WHO has defined osteoporosis based on bone mineral density, which is a kind of or the automatic kind of this reduction from the scanning that we do, the computerized scanning. And if you find that the bone mineral density is within one standard deviation, the mean for a young adult reference population, it is considered normal. That is usually referred to as T score. T score 0 to -1 is normal, while a bone mineral density where the density is between -1 and 2.5 is called low bone mass or osteopenia, and is referred to as T score -1 to -2.5. Osteoporosis conventionally defined as a T score below 2.5 standard deviation of the young adult reference population. And severe osteoporosis is when the things are same but with one or more fractures. There is another term called Judd score, which is a kind of score which is age matched, and this kind of scoring is usually looked in younger people and in premenopausal women to see is there any other kind of secondary cause of osteoporosis other than the age-related problem. The second point is that we have not defined what is osteoporosis and what are the risk factors in the context of chronic kidney disease. But when do we suspect osteoporosis in CKD is the moot point. Most of the patients of osteoporosis are asymptomatic. And these kind of things are usually seen in stage 4 and 5 of disease. But few patients who complain of symptoms, they complain of back pain, and few patients can have a spontaneous fracture or a kind of a fracture without any major trauma. So when you have this kind of presentation where the person has fractured the bone without any major kind of trauma or having back pain, and if patient is having a kind of chronic kidney disease, one has to suspect that there could be a kind of metabolic bone disease, which or osteoporosis, which has to be looked at. The differential diagnosis of back pain in the context of chronic kidney disease also has to be remembered that all back pain is not because of osteoporosis. It could be because of mechanical problem of ligamentous strain, which is called lumbago. which will require a temporary kind of therapy with analgesics. Occasionally, we have lumbago-sciatica syndrome, a degenerative disease with neural cord compression or canal compromise presents with severe pain and which may require a more kind of sophisticated therapy, including uh, the surgical options and anesthetic options for pain relief. Metabolic causes of bone pain in the kidney disease could be osteoporosis, renal osteodystrophy, or Paget's disease. Inflammatory causes of bone pain in patient kidney disease could be ankylosing spondylitis, rheumatoid arthritis, or seronegative spondyloarthritis. Infective causes has to be always kept in mind because bacterial infections and tuberculosis infection of spine is not unheard of in patients of chronic kidney disease presenting with back pain. Neoplastic disease presenting with both kidney disease and the bone pain, like multiple myeloma, could be one of the presentation for the back pain. Other causes like trauma, congenital causes, or some referred pain because of pancreatitis or duodenal ulcer in a patient who is having back pain. CKD also has to be kept in mind. So we cannot only think about one disease. We have to look at the differential diagnosis of back pain in CKD. And radiologically, when we look at a patient osteoporosis with some X-ray, we have to consider the possibility of oxalosis, fluorosis, steroid-related osteopenia, and avascular necrosis, multiple myeloma, and bone infection, which will have a kind of different kind of patterns in the radiological assessment of bone pain and back pain. So coming back to the topic again, then when we talk about bone pain, back pain, and osteoporosis, we try to assess the bone strength by looking at the bone quantity or bone quality. The bone quantity will ultimately reflect the kind of the density of the cortical bone and the trabecular mineral density, which is not separately analyzed in the conventional DEXA scan that we do, where we are looking at the bone quantity. The bone quality could be understood by bone turnover markers, bone microarchitecture by radiological evaluation, bone micro damage by again sophisticated radiological test, and bone collagen properties by both bone turnover markers and the radiological evaluation. So the quality and quantity both has to be assessed, but commonly you are looking at the quantity because that is the easiest tool that is available. So the elements of bone strength, which increases the risk of fragility fracture in patients of due to osteoporosis in patient chronic kidney disease, shown in the slide, that there have been many variables which has to be understood in the appropriate context. The bone density, the bone turnover, the bone architecture, the bone mineralization, the bone cell apoptosis, the bone size, and the bone geometry. So these are the different domains which are usually evaluated by specialists to look at the bone strength. And the tools which are utilized to assess this bone strength is on the slide that we look at conventionally on the bone quantity, or we may even look for bone quality if available. The bone quantity is commonly uh, assessed by the DEXA scan or DXA scan, which is said, but it can underestimate the risk of fracture in the patient with chronic kidney disease. It has a low sensitivity of compared to the other types of tools, and it can be affected by the vascular calcification, which is quite common in patients of chronic kidney disease. The quantitative CT, though available, it has a high radiation, high cost, and though it can distinguish the cortical and trabecular bone, it is not commonly utilized for bone quantity. The bone quality is usually assessed by the high resolution peripheral quantitative CT scan, which has been reported to correlate with histomorphometry, microarchitecture of the bone, and good cortical and trabecular differentiation. But this is not widely available. It is costly, and it's usually assessing the distal sides of the bone and not the vertebral sides. The bone biopsy, though is considered gold standard, is invasive and it is limited by its availability, and it is only done when the diagnosis is not certain. The bone quality can also be assessed by DEXA coupled with this trabecular bone scoring kind of device, because these days these are added as software to the conventional DEXA tool scan. When we are having both the things together, DEXA and and trabecular bone scoring. It assesses the bone microarchitecture better. It can predict an additional kind of risk of the fracture, and but it cannot detect the mechanism of bone loss. In contrast, the bone turnover markers that we talk about can distinguish the turnover from low turnover to high turnover. It is non-invasive, but it suffers from the interference by the kidney dysfunction because some of the bone markers are renally excreted and could be falsely high. So TBS is the trabecular bone scoring is a kind of thing which is now available, which is specialized software added to the DEXA scan, and the vertebral fracture assessment tool is also available on the recent modern DEXA scan, which can give an additional information other than the quantitative T score or Z score of bone health. So radiologically, when we talk about chronic kidney disease, MBD, and osteoporosis, we get different kind of patterns, starting from the extreme pattern of high turnover bone disease called osteitis fibrosa cystica to low turnover bone disease of osteomalacia. Osteosclerosis is a part of high turnover bone disease. Osteoporosis could be present in any kind of combination with the thing that we talked about. There could be bone cysts, there could be osteonecrosis and fractures and vascular calcification. So these are the radiological counterpart of bone disease in a patient with chronic kidney disease. And this is how the reporting is done by the radiologist. But from the pathological point of view, we try to talk about the bone disease as high turnover bone disease or hyperparathyroidism in secondary in patient chronic kidney disease, or low turnover bone disease, or a kind of vitamin D deficiency or resistant state, or aluminum related bone health abnormality, or low PTH level. So low turnover bone disease could be autonomic bone disease and osteomalacia, and high turnover bone disease could be osteitis fibrosa cystica. Normally in a patient of chronic kidney disease late stage, usually we have mixed kind of pattern of both high turnover as well as low turnover bone disease. That is called mixed uremic osteodystrophy. So the basic difference in the bone concept is in osteoporosis versus CKD MBD, which is a kind of chronic kidney mineral bone disease with osteodystrophy. In the classical osteoporosis, which is considered as post-menopausal osteoporosis, there's calcium, phosphorus, PTH are all normal, and alkaline phosphatase usually normal with unless there is recent fracture. While in CKD MBD, the bone the disease associated with abnormality in calcium, phosphorus, PTH, and alkaline phosphatase. So this is an additional counterpart in the CKD MBD with osteoporosis may be there. So extraskeletal malformation, calcification, that is vascular calcification, is usually not seen in postmenopausal osteoporosis, but can be extensive in CKD MBD, and which could be an interfering factor in DEXA scan. So when we are trying to talk about this bone health in CKD MBD, we need to first of all exclude the CKD MBD related osteodystrophy before we talk about osteoporosis. The bone is not a kind of static structure. It is always getting renewed, and it undergoes a cycle of ARF cycle. That is, the first step of bone is activation of the osteoclast, then the resorption of the bone, and then formation of the bone. And this cycle of bone remodeling continues throughout life. And it is said that roughly 6 months is required for bone to become new. 1 month is required for bone resorption as well as activation and resorption cycle, and about almost the remaining 4 to 5 months is required for bone formation. So more time is required to form the bone and less time is required to resorb the bone. That is the kind of simple statement. So it takes roughly 3 months to 6 months to get the whole bone renewed. 3 months is done is happening in a situation where the bone cycle gets activated, and 6 months is the conventional type of bone remodeling. This is a cycle which is a very organized cycle, and when it gets disorganized, like in patients with Paget's disease, you have different kind of bone ill health. So when we talk about bone markers, we know that there are few markers which are called resorption marker. That is the first step of uh, bone formation cycle. And there are certain markers which are called formation markers. And what is shown in this slide is that there are various kind of bone markers which could be used to assess the bone health. The most widely used bone turnover markers are PNP and CTX. PNP stands for this pro-collagen type propeptide, either N-terminal or C-terminal, and CTX stands for this C terminal telopeptidase. But these things get accumulated in chronic kidney disease, and hence it is not useful. What we use in chronic kidney disease, intact PNP, that is not a total PNP, the intact PNP, this bone-specific alkaline phosphatase, and TRAP 5B or tartrate registered acid phosphatase, which are not influenced by renal failure and can be used in CKD. So these are the bone turnover markers which can be used when available in context of chronic kidney disease for assessing the bone health. So the pathogenesis of osteoporosis in CKD is shown in this slide. There are two spectrums. One is the low turnover osteoporosis spectrum, other is called high turnover osteoporosis spectrum. In the low turnover osteoporosis spectrum, basically this is a deficiency of parathyroid hormone, which is because of either parathyroidectomy or because of PTH resistance or because of suppression of PTH by certain drugs, age, diabetes, uh, aluminum intoxication, and increased WNT inhibitor levels in the blood. So this could be because of various factors, the commonest being parathyroid deficiency or parathyroid resistance with aging and diabetes. On the other side of the spectrum is high turnover bone disease, where you have more kind of parathyroid hormone associated with phosphate excess, reduced calcium sensing receptor, reduced calcitriol level, and increased FGF23. And OPG rank cal disturbance, which can lead to a kind of high turnover bone disease, which is classical being a kind of osteitis fibrosa cystica. There are many other factors which may turn the tide to one direction or other direction, like uremic toxins. Many yes, medications like steroid can lead to low turnover disease. Metabolic acidosis can lead to again a kind of high turnover bone disease, and disturbed gonadal hormones, which can also lead to any specific type of osteoporosis, low turnover or high turnover. So there are various factors, and when we make a diagnosis of low turnover osteoporosis, it is basically you have to give drugs which are anabolic in function, like parathyroid hormone. And when we're thinking of high turnover osteoporosis, we have to give drugs to prevent the resorption cycle, that is anti-resorptive cycle, like denosumab or other drugs that we'll discuss in subsequent slide. So the common investigation that we do to make a diagnosis of uh, bone disease or bone health in patients of chronic kidney disease uh, or in evaluating osteoporosis are grouped as usual investigation, which are green colored kind of label in this, and unusual investigations that are put as the red color indication, and the black one is one which is not commonly done. The calcium phosphorus alkaline phosphatase and intact PTH is the routine test that we do in a patient chronic kidney disease to assess bone health. Besides the DEXA BMD, that is the to assess the bone mineral density by the DEXA scan, and radionuclide bone study to look at the overall skeletal kind of uh, metabolic function, which are commonly done. The red colored this PCP or PNP, where we look at the intact molecule of procollagen peptide, which is a kind of bone formation marker, a bone alkaline phosphatase of bulk, a tartrate resistant acid phosphatase trap 5B can be done wherever it is available in patient of chronic kidney disease. Histological assessment, the high resolution quantitative CT or quantitative ultrasound and bone micro indentation index are probably available in the research center to be done, and they are not the part of routine investigation. So the combination of parathyroid hormone, bone alkaline phosphatase, or even the alkaline phosphatase, uh, can have a 90% sensitivity and specificity to separate the low turnover bone disease from high turnover bone disease to some extent, and that is utilized to decide whether to give anti-resorptive therapy or anabolic hormone. So this is a kind of study, a nuclear study for looking at the bone turnover. On the left side, you see the skull is showing a kind of intense uptake of the radio tracer, while on the left side, you see the skull is showing a kind of some uptake, but there are multiple hotspots in the skeleton. So one is a high turnover bone disease, and other is a low turnover bone disease with multiple pseudo fractures of osteomalacia, and this could also supplant the information that you're going to get from the blood biochemistry and the bone turnover markers. This was a patient of high turnover bone disease, an elderly man on dialysis, was having severe bone pain with very high PTH level. We're not with hypercalcemia. What we see is that in the systemic scan, we are seeing a kind of gland in the neck, which is a parathyroid gland, parathyroid adenoma. And this patient was considered to be tertiary hyperthyroidism because his PTH was not getting suppressed and was having hypercalcemia on dialysis. After surgery, patient's bone health improved. The Coming to the treatment options, we have talked about the diagnosis, the tools to make a diagnosis. Treatment options are simple, that lifestyle intervention is a part of therapy, which is a lifelong therapy. CKD MBD management will oscillate around calcium, phosphorus, and PTH control with or without calcium mimetics to control the hyperparathyroidism. Anti-resorptive or osteoanabolic therapy for treating the osteoporosis, and monitoring the bone health by 2 to 3 years, 2 to 3 yearly DEXA scan and bone turnover marker periodically, 3 to 6 months, depending on the need and availability. Treatment that should not be overlooked when we're trying to treat a patient of bone disease in the context of chronic kidney disease is that correct the acidosis with the bicarbonate in the range of reaching to 24. Vitamin D level to correct with cholecalciferol, because that is a therapy which is easy to do and target is more than 30 nanogram per ml in child and possibly also in adults. Calcitriol is to be used for low calcium and for control of hyperparathyroidism in CKD if needed, and not as a routine for vitamin D deficiency, because that is one of the causes of low turnover bone disease if we over suppress the parathyroid hormone. Newer drugs like vitamin K2 has been found to have some role in bone health, and this could be a part of calcium vitamin K2 based therapy for bone health. Exercise has favorable effect on calcium homeostasis and bone turnover because it downregulates the inhibitor pathway, obstruction pathway, which leads to more anabolic effects. Therefore, the available molecules for osteoporosis in CKD are shown in the slide. The anti-resorptive molecule, uh, like bisphosphonates, rank ligand inhibitor like denosumab, and hormonal therapy like oral raloxifene. Anabolic agents like parathyroid analog, PTH analogs like teriparatide and abaloparatide, and drugs which has got both anti-resorptive and anabolic functions like anti-sclerostin antibody like romosozumab. And all these drugs have been used in patients of chronic kidney disease with different kind of results. So the options that we have to treat a patient of osteoporosis in CKD is to use the anti-resorptive therapies as bisphosphonates and denosumab in high turnover bone disease patients, and osteoanabolic therapy like teriparatide and abaloparatide to improve the bone health in patients with low turnover bone disease. High turnover bone disease, to treat hyperparathyroidism, you have to treat hyperparathyroidism before we give anti-resorptive therapy. In low dose bisphosphonates have been found to be safe on hemodialysis versus denosumab to be used not on patients who are on hemodialysis. Low turnover patients are basically treated with for osteomalacia before the osteoanabolic therapies of teriparatide and abaloparatide is used. So before we use this drug option, we need to look at that we have treated the underlying other factors which should not get aggravated with the newer therapies that we may give for bone health. So this was a patient of secondary hyperparathyroidism, having a kind of brown tumor in the leg, He was on dialysis for 10 years, and after treating his hyperparathyroidism with appropriate drug like calcitriol and sinacalcet, the bone cyst, a brown tumor, got filled with the bone, and what is shown in the slide in the second half of the X-ray is showing that the bone brown has got tackled by using inappropriate drug to treat hyperparathyroidism. So the 10 points that we should remember when we see a patient of bone pain with suspicion of osteoporosis is that we need to be clinically aware that this could be a possibility in a patient of kidney disease, because if you neglect it, there's a risk of fracture. You should consider the fracture risk in all the patients of chronic kidney disease by looking at the traditional and CKD associated fracts and other fracture prediction tools. Because if you ignore the musculoskeletal symptoms, there's an increased risk of vertebral fractures and the fractures of the femur. Medications which are said to be of bad for the bone health should be excluded in the therapy if possible. They're particularly corticosteroid sparing strategies whenever it is possible, like in a patient of SLE for long-term therapy. Consider the dose, indication, timing of agents that may increase the fall risk, like using gabapentin elderly can increase the risk of fall. Consider discontinuing drugs that may negatively affect the bone health that we talked about, basically the steroid and diuretics. Do not prescribe systemic corticosteroid without fracture risk assessment. That when we're trying to give a corticosteroid therapy, you need to look at the fracture risk before prescribe the drugs. Musculoskeletal function should be assessed by physical performance and overall frailty by encouraging patients exercise, whether person can walk or not. And we should not neglect the importance of recent falls if the patient gives a history. Dietary calcium, vitamin D intake should be assessed. And vitamin D is usually assessed by 25 hydroxy vitamin D level and not 125 hydroxy vitamin D. Assess the calcium intake. Biomarkers of mineral bone density that we talked about, calcium, phosphorus, alkaline phosphatase, and bone alkaline phosphate available, including 25 hydroxy vitamin D and serum bicarbonate, should be part of assessment. The biomarkers that for bone formation, that bulk intact PNP and reduction markers like TRAP should be utilized when available to monitor the treatment responses. But we should not neglect the traditional bone turnover markers that we commonly do, the calcium, phosphorus, PTH, and vitamin D. We should not do the markers which are available in the market like the CTX and total PINP, which are interfered by kidney disease and may give a misleading kind of high turnover report. Imaging is a must in all patients who are above the age of 50 years, and including the vertebral fracture assessment by the tool that may be available with DEXA scan. In case it's not available, we should consider a lateral X-ray for prevalent vertebral fractures and abdominal aortic calcification, because they are the indirect marker of vertebral risk. But we should not perform DEXA scan without a plan of action for the results. That if this is the report, what will you do? Novel imaging can be considered, but it is not to be used routinely. Bone histomorphometry is only done in case of the problem is complex, and multidisciplinary team should be always involved to take care of such patient. But we should not succumb to nihilism that in case it is not there, we cannot do anything. So these are 10 points when we talk about in the context of assessing bone health in CKD. So we should be aware of the fracture burden in CKD, because patients of chronic kidney disease are increased risk of this reduced bone strength and fall, with the consequent prolonged hospital stay, reduced quality of life, and excess mortality. We have to assess the patient's risk by looking at is it above age of 50 years, is it postmenopausal, or has it received systemic steroid, and if so, we should look at the FRAX score, or look at the DEXA scan to see is it below 2.5, or look at the spine imaging of X-ray of the lumbar spine to see is there any vertebral fracture. Then the appropriate steps should be taken. The limiting the exposure of drugs is very important. That glucocorticoid, the exposure to be reduced, because it makes the bone low turnover. Loop diuretics increases urinary calcium loss, and hence one has to look at whether it can reduce the dose of diuretics. Proton pump inhibitor, which are commonly prescribed, reduces calcium absorption. and one has to look at that whether it can be discontinued. Anticoagulant particularly can interfere with the vitamin K metabolism, and hence the novel and NOAC could be a better kind of anticoagulant than vitamin K dependent anticoagulant. Anti-epileptic drugs could alter the vitamin D metabolism and increase the risk of fall and fracture. And hence we have to choose the appropriate anti-epileptic convalescent in case you are going to give it for a long time. And CNS affecting drug has to be used with caution, which is the commonest drug which increases the risk of fall fracture, because patients are having a lot of pain and many people are getting multiple combination of drugs, narcotic drugs, including gabapentin and uh, non-steroidal, not non-steroidal, but drugs which has effect on the CNS, which can make the person sedated and the risk of fall. So we have to look at this, that this can ultimately have an indirect kind of benefit for bone health. So we should provide sufficient dietary calcium, and by the sufficient dietary means we should give at least elemental calcium of 1000 milligram, but not exceed 1500. And vitamin D has to be supplemented to keep in the right range of 30 nanogram per ml. There are certain imaging which has to be also remembered, that the novel imaging are not available at most of the places, but trabecular bone scoring, hip strength analysis, 3D DEXA, finite analysis, and REMS are the newer kind of tools which can give an idea about the bone strength and bone quality, which will be the order of the day in future. Bone biopsy only considered in complex cases, which is not because this is not freely available. It is said that any person who has history of atypical and multiple fractures, divergent biomarkers of the bone biomarker, atypical mineral metabolism profile, important comorbidities and malnutrition, endocrine disturbance, and not improving, this could be considered. There are various research tools like calcium isotopes diagnostics, bone impact microindentation by osteoprobe, this positron emission tomography using 918F sodium fluoride, and this can be utilized as a research tool for bone health. Cathepsin K antagonist, the Odana captive was earlier utilized, which is basically expressed in osteoclast, but unlike the sclerostin, which is expressed by the osteocytes, but has gone out of use because of the side effects. Sotatercept used in activin trap is also a drug which is being talked about in literature, which has effect on anemia correction and bone health. The activin trap or sotatercept was found to be an interesting drug with the potential for not only correcting anemia but also checking osteoporosis. And as both the problems are there in CKD, this may be a good drug if it is approved in future. So practical algorithm for making a diagnosis and therapy is shown in the slide, that if you suspect a patient to have osteoporosis based on the risk factors, do a DEXA scan, do a T-score, VFA, that is the vertebral fracture assessment, and FRAC score. And based on that, we need to decide. All patients will be instructed with the non-pharmacology intervention that I talked about, control the CKD MBD, use anti-osteoporotic therapy based on the turnover markers, high turnover, anti-resorptive, low turnover, osteoanabolic therapies. And if you have borderline, we may have to do a biopsy or have a close follow-up to decide what to do based on the combination of bone turnover markers and DEXA scan. Simplistically speaking, when the patient GFR is below 60, the patient has risk factor for fractures. Besides lifestyle intervention, CKD MBD management, DEXA scans will be done every 2 years. The T-score is below 2.5 with or without fracture. We proceed with the therapy. The drugs therapy is based on the bone turnover markers, that is bone alkaline phosphatase and PTH. The bone alkaline phosphatase or the alkaline phosphatase is more than the median range, along with the PTH above 350 picogram per ml, then it requires anti-resorptive therapy. And if it is on the other side, that PTH is below 100 and the bone specific alkaline phosphatase is on the lower side of normal, it requires an anabolic agent. In case it is in between, you need to follow up to decide. So to conclude, the osteoporosis management in patient of chronic kidney disease is not only a drug management, and non-pharmacological elements of balanced diet, stopping smoking, limiting alcohol, doing weight bearing exercise, and preventing falls is required in all the patients. Pharmacological treatment for CKD MBD is required by appropriately targeting calcium, phosphorus by phosphate loading therapy, vitamin D and vitamin D receptor antagonists and calcium mimetics in majority of the patient. In selected patient, we may use anabolic approach for teriparatide, abaloparatide, or romosozumab in patients who are having kind of low turnover bone disease, and bisphosphonate, denosumab, and SERMs can be utilized for high turnover bone disease. Parathyroidectomy may be required in patients who have a kind of refractory hyperthyroidism or tertiary hyperthyroidism. So to conclude, osteoporosis in men and women with CKD results in 4 times the fracture compared to general population. In CKD, the bone mineral density based on the DEXA scan, a FRAX tool, which is can be used to discriminate the fracture risk. With the evidence of low turnover bone disease based on the PTA less than 2 times the lab raise, or bones specific alkaline phosphatase, or conventional alkaline phosphatase in lower days, PTA, PTH analogs can be used even without bone biopsy. In patients with progressive CKD, denosumab is preferred for treating high turnover bone disease with low dose bisphosphonate at the completion of therapy or on dialysis. Phosphate binders should be used in patients on dialysis for prevention of secondary hyperthyroidism along with calcitriol and cinacalcet after the vitamin D deficiency has been managed. So that is all that I wish to share about the osteoporosis and CKD management. Thank you.
Thank you so much, sir. Thank you for your wonderful insights and for sharing this with us. Moving ahead with the question answers round, we have received few questions from the participants. So with all your due permissions, I would like to put across those questions to you.
Yes.
So the first question is related to the role of denosumab in treating osteoporosis and CKD. So what is the role of denosumab in treating osteoporosis and CKD?
Denosumab has been found to be a safe drug in chronic kidney disease patients, particularly who are not on dialysis, because denosumab can produce the risk of hypocalcemia, which could be a problem in a patient on dialysis. So this is a drug which is a preferred drug, which has got no impact on the kidney function, and can be used in patients whose calcium levels are normal and who are not on dialysis. But in a patient who is on dialysis, the drug has been used but has not been yet recommended. This is a last line option, and that can be utilized after taking care of the calcium level in patients on dialysis. It is said that the low dose bisphosphonate is safe on dialysis, and that can be utilized in patients on dialysis, while the denosumab should be utilized in patients off dialysis for as an anti-resorptive therapy in a high turnover state. Bisphosphonate can be used till the stage 3 is CKD, that is till the GFR is 45. And after that, it is not recommended to be used because it can increase the risk of CKD progression.
Thank you so much, sir. Thank you for answering that question. Moving ahead with the other question, and the other question is related to the medications. So which medications are typically contraindicated in patients with CKD experiencing osteoporosis?
It is said that bisphosphonates should not be used in patients who are having advanced CKD, that is when the GFR is below 30 ml, particularly. But in patients who are already on dialysis, this can be utilized to take care of the high turnover bone disease to reduce the risk of fracture. So that is only contraindication for bisphosphonate. For this denosumab, it is said that when you use denosumab, though the experience is limited on dialysis, one has to take care of the calcium. Calcium should be in the right range because it can produce severe hypocalcemia in the follow-up, the risk of seizure in case the calcium is not corrected. So safer option is to use denosumab in patients who are not on dialysis, and use low dose anti-resorptive agent that we talked about on dialysis with a similar kind of benefit. The other drugs, that is hormonal therapy like SERMs, raloxifene, has increased risk of DVT and as well as thromboembolic condition. Hence, it has not been recommended, but it can be utilized. The other drug, the anti-sclerostin antibody that we talked about, can be used, but the experience is limited in this context.
Thank you so much, sir. Thank you for answering that question. That was the last question for today's session. And I would like to thank all of our viewers for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such interesting questions to us. And I would like to thank you as well, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful insights with our viewers here present. So thank you so much, sir. Thank you.
Thank you.
With this, we are concluding the session here for today. Until next time. Thank you, everyone.
Thank you.